Hey chiropractors, and welcome to another episode of Mic'd Up with Chiro Up. You might be wondering, who's this guy? Well, this is Effie, and I'm part of the marketing team here at Chiro Up, and I just wanted to take a few seconds to let you know about our summer special. For a limited time only, you can pay for your first month of Chiro Up and get your second month for free. That's right, basic plus premium, any plan. You pay for your first month, the second one is on us. This offer does end on July 31st, so hurry, visit chiroup.com to get started. As always, there's no contract required, and this offer is valid on new subscriptions only.
Welcome to the next episode of Mic'd Up with Chiro Up. Brandon Steele here. Today's episode is going to go over some interesting things in our profession today, but also in the future. We're going to go over AI in chiropractic. And the reason I want to do this podcast is twofold. One, we have seen a lot of feedback concerning AI going into healthcare, and it's all been negative. However, I'm here to tell you, and the reason behind today's podcast is to go through the positives of what AI can do now, but realistically, what is it going to do in the future for our profession, not against our profession, because I do believe that chiropractors will always have a place in healthcare, and we can use AI to help us now and more so in the future to get better data, better patient responses, and now show insurance companies, the public, and legislation what we can do. The second piece is this, is that there's a lot of things that we've built into our program that utilize machine learning and AI for the future. That's not designed to hurt the chiropractor. This is designed to help you. So today we're going to go through those things. Now, as always, just a reminder, if you haven't yet, hit that follow button, share this episode with a friend. This is going to be one that's going to be a touch different than the clinical episodes. However, I also recognize that's one of the reasons a lot of people come to this podcast is the clinical relevance. So we're going to weave in technology and the clinical aspect of how we can utilize AI to get better clinical results. So it's been one of the fun things we get to do today. And always, please leave us a review. If you don't do either of those things, you don't share us, you don't leave us a review, do me a favor and be the impetus behind the next podcast and send me an email or send me any kind of correspondence with Chiro Up, because that's the reason we do this podcast. The reason I'm talking about AI, the reason I'm talking about my last blog on negative orthopedic tests is because of the feedback of our subscribers. So hopefully we can dive a little deeper in an audio format of what the last blog is and the concerns of our subscribers. So what is today's blog really going to be about? It's really going to talk about the diffusion of information. It's going to go through a lot of the stuff the chiropractic profession can do now, but also in the future to change healthcare that really is going to benefit us and also the patient. And then really, where do we stand in the future? Where do we stand as a conservative custodian of our patients' healthcare? Really taking a look at what we can do to assess, document, and also, of course, heal our patients. So today's topic on AI and chiropractic, we're going to dive right in. And the first time that I used OpenAI, I want to share a little story on that. For those of you who've never used OpenAI, it's a program you can get on the internet, and it's an AI engine, and it's fun. But it's just that. It's just fun. You can put in there and you can type in there, create a note for a 61-year-old male with right-sided shoulder pain, and you can create a soap note, and it looks phenomenal. None of it's right. However, it can do some really cool things when you give it the right information. The first time that I saw that, it reminded me of the Jetsons. And for those of you who grew up, I was born in 1982, but grew up in that era of Sunday morning cartoons, you'll probably remember the Jetsons. But the Jetsons were created, and I think they went out in 1962. It was set in 2062, so it was a 100-year, what the world was going to look like in 100 years. But the cartoon was about flying cars. It was about talking dogs. And then it was also an AI engine or a robot that talked. I believe her name was Rosie. However, here's the really cool thing about this program that I didn't know until I went and dove in a little bit deeper into the history, is that this was a really special show. This is a show that broadcast. It was the first program that broadcast in color on ABC. Now, before that, it was all black and white. Now, there's only a handful of stations that were even capable of broadcasting in color. This was the first one that broadcast in color. So 24 episodes aired that year on ABC, and it aired at night. So what do you think happened? Well, it flopped. Why did it flop? It was canceled the first year, but it flopped not because it wasn't a great idea. In 1962, we have a cartoon about the future that was truly, broadcast in the future in color. However, right idea, wrong audience. The cool thing about this show that, of course, affected me is it came back in the 80s on Saturday morning, and it was wildly successful. It was back when, color was a little more prevalent. However, this is a really cool lesson to be learned that regardless of how we think about it, AI is going to affect us all. The question is, are you the right audience? Because the future is here. The question is what you're going to do with it. Are you an early adopter? Are you in that majority of people? Are you a laggard when it comes to technology? And I think this is where the cool part about this that I want to talk about is that when you talk about the diffusion of innovations, which is interesting, the person who came up with that, Rogers, also in 1962, which maybe is a coincidence, maybe it's not, but it talks about whenever we look at customer segments of technology adoption, where do people fall? And it really has nothing to do with the technology. It has to do with the person, and that 2.5 people, the percentage of people in the population are innovators. They're willing to kind of be the first to adopt an innovation. These are people in 2007. They were the first people to buy the iPhone. These are the high risk tolerance people. They're fairly young in age, usually a little more financially sound, high social and scientific, education. And then the next time we have we go right on that population. We have the early adopters, the next 13 to 14%. And these are the people that are also younger in age, higher social status, usually advanced education, a little more socially forward people. These are the first two groups of people that want to adopt technology. However, when we look at those things, where does chiropractic fall? And I think that's where most people are getting into the comfort of their own practice. I've been doing this for 15 years, 20 years. I don't want to start something new. I don't want a new EMR. I don't want to use new programs. I just want to keep on doing what I'm doing. However, my argument would be is that it's really not about you. It's about your patient. Let's take this into consideration. If you have a patient that comes in who is 21 years old and you want to give them paper handouts of all their exercises, they're going to look at you like you're crazy. What do they expect? They expect at least an email of their exercises, possibly a text message of their exercises, but realistically, they want this done on an app. They want it to be updated on a regular basis. They want communication back and forth with you. That is what they expect. Now, the same argument could be the exact opposite for a 75-year-old female with plantar fasciitis. If you gave her an app to download on her smartphone, it's probably not going to happen. So we need to take those things into consideration, that it's not about us as a provider, it's about what the patient expects. For example, does a patient expect when they go into a doctor's office to put their name down, their birthday down, and their condition down 7 times? Yes, because everyone is still using paper on their intake forms. However, if we can find a way to make this simpler, we're going to affect all populations. Now, with that being said, we're talking about AI. I really want to go through the reason why chiropractic is going to be so popular in the future, because there really are 5 main constraints currently limiting AI from taking over healthcare. Now, I don't believe these are solvable problems, and I could be wrong. However, they are solvable with the insertion of a highly capable chiropractor. So first off, we have the complexity of musculoskeletal disorders. I'm going to go through each one of these in detail. However, we have the complexity of musculoskeletal disorders. We also have variability in symptoms and how your patient presents those symptoms. We have limited data, meaning all the data is in different EHRs or different data pools. We need to combine all that together. We also have the ability to replicate nuanced decision making. This is one of the cool things that we can do as chiropractors that's very difficult on a machine. And the last one, which is, I think, possibly the most important, and I'll talk about at the very end of this podcast, was how does AI handle uncertainty? And it doesn't do a very good job. It needs very good data coming in. It's going to have very reproducible data coming out. However, what happens when the data coming in isn't that great and can be taken in multiple different opinions? So, first thing, let's talk about the complexity of musculoskeletal disorders. Well, I would love for this to be more simple. The simple fact is it's not. I mean, the human body is a marvel of complexity. If you look at a condition like a fracture, a sprain, a strain, arthritis, they can all manifest in a myriad of ways. They can all present with their very unique symptoms, but they can all actually present with very similar symptoms. And for AI systems, this variability poses a significant obstacle. Algorithms excel at processing vast amounts of data. The nuanced interplay of symptoms and diagnostic nuances in musculoskeletal disorders just really has confounded the most sophisticated models that we currently have. And I think the reason kind of boils down to one of the things that we focus on at ChiroUp is Gall's law, Galls law, in that a complex system that works is invariably found to have evolved from a simple system that has worked. So really what you need is a very simple system that works, and as you have that, you can make it more and more complex. However, let's take one step back and forget about AI for a second, and let's look at the patient. Let's look at healthcare right now and to see what problem, what system are we really trying to create. Now, this is an important distinction. Let's think about this. If you're a patient that comes in to see a chiropractor, what do you want? You want to solve your problem as fast as possible at the lowest cost, right? That seems reasonable. What if you're a provider? You want to solve a patient's problem as fast as possible at the highest reimbursable amount, right? I mean, it is what it is. We all have a clinical hand. We all have a business hand. Now, the next two have a little bit of opinion tied into it. However, what does an insurance company want? They want to solve the problem. I truly believe they want you to solve that patient's problem. But they're also going to increase paperwork to delay treatment because hopefully the patient's going to heal by themselves. And they're also going to increase costs so they can increase premiums and then increase the bottom line because they can only take a percentage of whatever their profits are at the end of the year. What does the government want to do? Well, they just want to slow down everything so they can triple check the math and then tax everything a little bit more. That's a little bit of opinion. However, I thought it was pretty funny. But today, let's talk about this. We're going to talk about one simple system that must work for the complex AI algorithms to work. And that is the most important thing that we can possibly do. It's collecting standardized data to make sense of the outcomes. What does that mean? What does it mean to collect standardized data? And this is something that may sound like, oh, what are we going down? I don't want to give my patients more and more surveys and more paperwork to fill out. However, if you really think about the complexity of musculoskeletal disorders, we all do a history. We all do a physical exam. Sometimes ours looks and smells a little bit different. Some of us perform diagnostic tests. Some of us do orthopedic exams. And then we kind of boil all those things down when we bring the patient in and combined with the education of the provider. And then what we get is this powerful thing called the diagnosis. Once we have the diagnosis, we forget about everything that just happened and we say, okay, for this diagnosis, whether it's lateral epicondylitis or rotator cuff syndrome, here are the things that I do for that diagnosis. I do manipulation, I provide some ADL advice, I do some manual therapy, I provide some patient education, I do some supplements, supplies, whatever it may be that you do for that diagnosis. However, there's an uncoupling there. There's an uncoupling because maybe the patient told me about poor sleep, but that's not something I consider to do for, rotator cuff syndrome. So we need to make sure that whatever the patient tells us and whatever we find in that beginning initial evaluation, that also goes through the diagnosis and infiltrates what we do for that patient. Now, what happens if you don't ask the right questions? What happens if you don't do the best orthopedic exams? What if we don't stay up to date with the how to evaluate that specific condition, or we order the wrong diagnostic test? That's going to possibly give us the wrong diagnosis. So data collection is extremely important. And I'm going to go through a little bit of a case here, but I'm going to do it as far as a clinical case, but I'm going to do it for a reason to talk about data collection. Let's take a patient. We're going to call him Mr. Steele. He's a 40, oh, what? I guess I'm 42. I am 42. 42-year-old chiropractor with no red flags, no trauma, and a self-proclaimed athlete in his past. Well, what happens if Mr. Steele has shoulder pain? The pain's been going on for a long period of time. He has weakness upon activity. It happens 4 times a year. It hurts every time he goes out and throws BP for his teenager. It's worse with overhead activities, and it actually is worse at night. Well, let's think about this patient. That this patient's diagnosis actually is going to come from my education. It's going to come from what questions I ask, how in-depth of an orthopedic examination that I've done. Because if I don't do all those things and I don't ask the right questions in my history and I don't perform the right diagnostic tests and I don't do the right orthopedic exams as far as positive and negative tests, his diagnosis is actually going to change based on my interpretation of what I heard and what I felt. Let's assume that a standard manual therapist, maybe it's a PT, maybe it's a chiro, maybe it's a medical doctor. Let's just say they poke around in the muscles and they move some joints. Say, well, you got some tight joints and you got some trigger points in these muscles. You've got a sprain strain. That's okay. We can have that. And in fact, we have to use ICD-10 diagnoses to get paid. It is what it is. It's like Common Core math. It's right 50% of the time, every time. However, depending on the provider, determines what diagnosis they give that patient. So I could have had 10 different patients come in with the exact same history. However, I did a very different examination, and all 10 of the chiropractors came up with a different diagnosis. However, what if the diagnosis was wrong in that person? Because in that person that has weakness and pain over their head and pain at night, if I just call it a sprain strain and I provide typical treatments like ice and anti-inflammatories and rest and maybe manipulation for the joints that are restricted, that's not the right diagnosis. Weakness isn't going to present like that. What if they had a partial or a full thickness tear of the supraspinatus, let's say, the most common tear in the rotator cuff? Well, did you do the external rotational lag sign? Did you do the internal rotational lag sign to rule out those muscles? And did you perform the dime test to determine weakness in that supraspinatus? Yes or no? Because those are the biggest things. If we get that data coming in as far as what the patient is presenting with, do we perform the right test to come up with the right diagnosis? Because if there's any breakage along that chain, unfortunately, I'm going to perform the wrong things as far as treatment. If someone has a partial thickness tear, a full thickness tear, am I going to prescribe them rest and anti-inflammatories and ice? No, I'm not. And if I do those things, what is going to happen to the patient? They're going to feel better in the short term, but not in the long term. Patients want to feel better, and they want to see that problem go away forever. And if they don't get that relief from you, what are they going to do? They're going to go get a steroid injection. And what do we know about steroid injections in the subacromial space is that now we're increasing the risk or increasing the incidence of them having shoulder surgery 1 to 3 times. What do we know about shoulder surgery? Well, it provides, and this is quotations, it may provide little or no clinically important benefits with respect to pain, function, and overall quality of life, and that's from a Cochrane review in 2019. So if we don't ask the right questions and we don't perform the right set of tests, and maybe we don't get that patient out of pain, they're going down a path of traditional allopathic care that isn't great for that diagnosis. Now, if I've done my homework and I understand that patient presentation is usually more of a tendinopathy, and I'm able to do eccentric exercise, I'm able to do instrument system manipulation or dry needling or extracorporeal shockwave therapy, and I'm able to prescribe the right set of rehabilitation exercises, now I'm on the right track. But if that patient also told me they had a problem sleeping or picking up their arm over their head, and I don't give them the ADL advice or the rehab exercise to control their scapula, unfortunately, while I can get them out of pain, if they keep on doing the same things over and over again to create that pain, the problem is just going to keep on coming back. So data collection for musculoskeletal conditions is important because of how complex these things are. That if we don't get the right diagnosis, we don't know what the treatment should be. And what we know as far as manipulation, I love manipulation. Second favorite thing to do in the world. However, with manipulation, It is so powerful and it's such a good pain reliever that sometimes we get lulled into this, well, let's treat it a couple times to see how it feels. Because with manipulation, they're probably going to feel better, at least in the short term. However, not all of our patients are going to get better with manipulation only. While I wish it were the case, it's just not. But if we get better data, we perform the right set of tests, we have that right standard of care per condition, we know what to do and how to treat it, it's really going to help fuel AI. Because let's think about this. That pattern of intake of information led to a diagnosis. What if that diagnosis was wrong? Don't you want to know? If everyone else in the world called it diagnosis A and you call it diagnosis C, that'd be cool. I'd love to learn that. Well, what about if for diagnosis A, you perform, manual therapy and manipulation for all your patients? That's fine. But what about for diagnosis C, if you do manual therapy, we do manipulation, and we do, acupuncture, and everybody gets 20% better? Wouldn't you want to know that? That's going to be the power of AI. Now, the variability in symptoms is the next problem with AI. That's the next one that I want to get into. The muscular pain is highly, highly subjective, as each and every one of you know. When you go person to person, all those patients walk in your door, the factors that people come into, the location of the pain, the intensity of the pain, the duration of pain, the accompanying symptoms for the same diagnosis can be different between individuals. And this variability presents a huge challenge for AI. Because if its responsibility is to accurately interpret that information and then suggest or create a diagnosis based on these presentations, it's going to be extremely difficult for that program. However, as a chiropractor, this is where we come in, is that patient-provider interaction is going to be critical in asking the right questions to come up with that diagnosis and then really to discern symptoms, say what's really there, or maybe what's a layer of maybe an alternative pathology or compensating pathology. So really, your astute judgment is going to help standardize that intake data. For those of you already using the Chief Complaint Survey in ChiroUp, what you'll recognize is that we ask very similar questions at the beginning of the survey, regardless of the person, and then those survey questions actually change based on their responses. Now, our average person right now is taking about 2.5 minutes to go through that intake survey. Now, the beauty of that is, one, it's their 2.5 minutes, not my 7 minutes of listening to their story, and then another 5 minutes of documenting it. They're actually taking all that information, getting it into the survey system, so it actually populates on my screen before I even see them. And then also, they're able to fill out the appropriate disability indice associated with their complaint. However, one of the things about this is that we can now standardize that pattern of intake. That's going to be pretty cool because now I can take, thousands, hundreds of thousands of intakes, and I can say, okay, for these intakes, here are the most common diagnoses that chiropractors make. And then also, here's the most common treatments that a provider may make. Now, this is going to be critical as far as patient satisfaction because we know we're giving them the best treatments, and patient outcomes because we're able to go in there and say, you know what, if I can add this treatment, if I could take away this treatment, what can I do to be more efficient? And then at the end of that, we're able to now take an approach based on insurance company rules, based on clinical rules and standards of care. And we can say, what should we be providing for this patient and what should we be billing for this patient to make sure that everybody is treated fairly. Which is going to be something that I am, I never thought I would say this as a chiropractor that I think that is rooted more clinically than business. However, can you imagine having a billing scrubber and a clinical scrubber? I mean, that's really what this is coming down to. Do your notes support your charges? Think about that. Think about what you just did yesterday. Were all of your charges backed up in your notes? And then think about it one step a little further back. Do your notes support your diagnosis? Meaning if you have a diagnosis, I'll just use shoulder again, since we talked about that, that if I said they have a impingement syndrome of the shoulder, well, do they have a positive Hawkins-Kennedy? Do they have a positive NIRS? And do they have a negative DIME test? Meaning they do not have a weakness. You can think about that for every single diagnosis, those positive and negative tests, because that's going to help fuel what your note should be in there. I mean, if I say if they have a diagnosis of plantar fasciitis, or if they have a diagnosis of, sciatica, do I have the appropriate orthopedic findings in there to make sure that I, have a medically necessary diagnosis and rationale behind that treatment? Something that's pretty cool to think about. Now, here's one thing that it's not abstract. However, this is one thing that I think limits the chiropractic profession that is going to be enhanced with AI. So one of the problems with AI is limited data, because AI algorithms rely heavily on data for training and decision making. And there's a wealth of medical data available, including electronic health records. We have research articles. We have imaging studies. But there's gaps and there's biases in these data sets that have been used to train AI models. So the way that musculoskeletal diagnoses are going to be currently created are based off, personally, I think, bad data. We need better data. So the quality and consistency of data collected in a chiropractic practice is crazy variable right now, which is going to further complicate any ability of AI to generate an accurate diagnosis, ideas on what to do with patient care. So really what we need is that comprehensive and standardized data sets. I do believe that if we had those, then AI could help us in our diagnosis and in our treatment. However, one of the things that I allude to at the very beginning of the podcast is, how can the chiropractic profession combat changes in healthcare? And these changes in healthcare currently really don't benefit the patient. I think the answer to that is better data. So I think we need better intake surveys for our patients to get better patient satisfaction, to decrease cost, and then, of course, to increase clinical outcomes. But the data has to be standardized. You know this, and I think I know this, is that if I send one patient to 10 chiropractors, how many different diagnoses are they going to get? Probably 10. How many different kinds of treatments are they going to get? Probably 20. And no one's going to measure their outcomes, and all their notes are not going to substantiate most of that. Now, I say that as maybe disparaging the chiropractic profession, but that has nothing to do with the chiropractic profession. That's everywhere I go. When I send a patient to pain management or for surgery or even worse to PT, I get a very similar response. And once again, I hope that doesn't come off as a negative. That's just the world of musculoskeletal care. There's always just random diagnoses and things that are done to patients that don't make really any sense. Yet think about this, is that if you have a young kid and that young kid has an earache, maybe they have a fever, and you take them to their pediatrician, I can take them to a pediatrician in St. Louis, Missouri, where I am. I can take them to Alaska. I can take them to, Fort Lauderdale, Florida. Guess what they're getting? Some form of amoxicillin, some antibiotic that's going to help that ear infection. Now, whether that's right, wrong, or indifferent, I'm not making a distinction whether an antibiotic is the right decision. However, that is a standard of care. It's very similar to the McDonald's cheeseburger story. It's the same crappy cheeseburger no matter where you go. I don't really care if you're in St. Louis or Anchorage, Alaska, or anywhere else. It's the same crappy cheeseburger. But the word there is important, is the same. Meaning, if we're going to scale our profession, we have to have some kind of standard of care. Because right now what we have is a fruit salad. We have a fruit salad of diagnoses and treatments that we do on our patients. And unfortunately, what it creates is bad data, because we don't know what to do for patients because everybody's doing a little something different. Now, I love the variability we have in our profession. I love the fact that you can do functional medicine, you can do sports-specific rehab, and some people do different things in their practice. So I don't want to say anything bad about that. But I think the reason we all do a little something different is because of the fact that the musculoskeletal system is so hard. One of the most interesting things that I came across in my research for a different talk, this was for, I think the first time I talked at Parker was on chronic pain. And what's interesting about, if anybody's ever been to Parker seminars, when I was in school, they had a very different reputation. And I'd say over the last several years, maybe in a decade, it's turned into a really cool event. And I think that the reason it's turned into such a cool event is one leadership. However, the other piece is that they give the speakers autonomy. Whenever I go out and speak, I talk about the shoulder, I talk about the back, I talk about the foot, I talk about the musculoskeletal structures and peripheral neuropathies and those kind of things to different organizations or state associations or hospitals. That's fun. I enjoy doing that. But Parker's a little bit different. Parker says, we just want you to talk for an hour. We just want you to talk for 2 hours. And the first question is, what do you want me to talk about? Oh, I don't care. Just talk about whatever you want to talk about. So the first time that I went there, I talked about chronic pain. The weakest point of my education is by far chronic pain. And one of the most highlighting things that I ever learned in that are these 2 sentences, is that pain in the absence, and this is chronic pain, which is, more than 3 months consistently or 6 months every other day. Pain in the absence of significant trauma, in the absence of red flags, does not correlate to structure. And you've seen that. I've seen that. Patients with a really bad arthritic back and they don't have no pain at all. And then someone with a shoulder and shoulder pain and you do some imaging and there's nothing there. So pain in the absence of trauma or red flags does not correlate to structure. Now here's one of the most interesting things. That's the first sentence. Second sentence is this. Function also doesn't match structure or pain. So this is crazy. And think about this. Think what you just did with your patient, an hour ago, whenever you saw your last patient. The one thing that I asked them questions on is pain. And the things that I assess are structure and function. So I can't deny those things. However, what we know is that it's not a one-to-one match. That when I talked about the complexity of musculoskeletal disorders, it's a combination of things. It's the symptoms, the history, the diagnostic test, the orthopedic test. It's we need to combine all those things. And pain is a very difficult thing. So when we talk about this, the limited data is possibly due to the variability within our profession, but realistically, it's due to there's not a great way to deal with musculoskeletal pain on a standardized method. When we look at what we do at ChiroUp, it's difficult. When you come up with a standard of care across all professions for a diagnosis, let's say plantar fasciitis, it's difficult. However, what we know is when we start to define things better, we really know how to treat it better. Everyone with foot pain does not have plantar fasciitis. Everyone with elbow pain does not have lateral epicondylitis. Everyone with shoulder pain does not have a rotator cuff tear. So as soon as we're able to now put these people in specific buckets, we can really help a much bigger population. All right, fourth problem with AI, and that is replicating nuanced decision making. So that sounds kind of complex. However, I really don't think it is, because one of the hallmarks in effective chiropractic care is the decision-making process that we make. That we are able to collaborate among us and other different specialties to take an approach to allow a holistic understanding of what the patient has and what we're going to do about them. What that means is this. If you have back pain, you don't need a muscle relaxant, pain reliever, and anti-inflammatory and come back in 30 days if the pain is still there. We just don't need that to happen. We know that doesn't work. However, as a chiropractor, when I can listen to what the patient has and I can go through and I can say, okay, I think you have this diagnosis, but after incorporating and listening to your medical history, after talking about your lifestyle, after thinking about your occupation, let's create a hierarchy here. Yes, I can do manipulation, manual therapy, and exercise, and I'm going to do those things. However, what's on my hit list? What are the things that I think are causing this problem? And then how can we attack those things first? Because let's be honest, if a computer system sat down and looked at you or looked at me and said, okay, Brandon, here are the 74 things you're doing wrong in life, I'm probably not making any of those changes. However, if a computer program said, listen, Brandon, here's the deal. You're going to die in 5 years. If you don't fix this one problem, I'm going to be a little more amenable to making a change in my habits, my hobbies, my sports, my activities. So while AI systems excel, at processing data, excel, it's kind of a pun on a computer program. Puns are the lowest form of comedy, but they do make me laugh every once in a while. That these programs, they just need help. that if we're going to replicate an expert, which would be the chiropractor, in this decision-making process, it really needs to be a collaborative effort. So our job as chiropractors is to get information into these systems and then understand the diagnosis or the suggestions they're making, and then making the best decision for our patient's life. And I think that's what we've started to do. So we're building a standard of care, not ChiroUp isn't doing the research. We're not building, what are the best treatments and exercises for cervical disc lesions. We're actually taking what the research says. We have a team of 4 people that every single day go through all the peer-reviewed, high-index peer-reviewed research and say, what is a standard of care? And they really do take a non-biased approach at the diagnosis, the management of these musculoskeletal conditions, and they just don't take into consideration the opinions of their friends, where they went to school, the historical data, a seminar you attended in 1974, a trend in literature. We look for how to define what is the best way to assess and also to treat these conditions. And now, with ChiroUp, get that real-time information in your hands so you can better diagnose the patient who's literally sitting in front of you. So do me a favor, dive into that condition reference section. One thing you're going to see in the near future is the ability to see positive tests, negative tests, and related muscles. And here's why, is that, and I alluded to this in the last blog, is that there's tons of evaluations you can do for a lumbar spine disc lesion or a rotator cuff tear or low back pain. There's hundreds of evaluations that have some research behind it. However, to make a specific diagnosis, you really need to know which ones are the typically positive tests, and then also dive into, I think just as important, what are the typically negative tests? Because if you look at, low back pain and your test is to bend over and touch your toes, well, they could have stenosis, a disc problem, joint dysfunction, facet syndrome, even a facet syndrome. They could have a ton of things, iliolumbar ligament strain. They could have 30 different diagnoses that would be positive if that was your only orthopedic test. However, negative orthopedic test helps us define the region and really dive into, is this definitely my diagnosis or could it be possibly something else? I just talked about a lumbar spine disc lesion. So let's think about this. Someone you suspect has a lumbar spine disc lesion. What test should be positive? Well, maybe Milgram's test, modified slump test, straight leg raise, Bragger test. Those are all realistic, typically positive tests. What should be negative though? Well, did you do a Faber or a Federer test to make sure it's not coming from the hip? Did you do Kempster-Yamas test to maybe it's to rule out a degenerative cause of pain? So those are things you want to think about. And then we can actually take those things along with the related muscles. So for like a lumbar spine disc lesion, what are the related muscles? Well, the quadratus lumborum, the glutes could be involved, the erectors, the iliolumbar ligament as far as another structure that could be affected. So when I dive into my note, and I see Sally, and Sally gives me her history, and I do my physical exam and my orthopedic exam, and I think that Sally has a lumbar spine disc lesion. Well, when I go back into my note, do I want to start just listing those things off and finding those and searching for those? No. If I already know the diagnosis that I think Sally has, I click on lumbar spine disc lesion, and now it's going to pull up and highlight what tests should be positive, what tests should be negative, and also allow you to make statements based on those related muscles, whether they're tender, whether they're spastic, whether they're trigger points or tender, whatever it may be, to make it easier on you to make those diagnoses. Now your note truly reflects that diagnosis and what you did in your practice. So when you can do all those things in coordination, really, you're going to get better results. And I do believe that all those things, when it comes to AI, has to do with a chiropractor. AI programs are not going to replace chiropractic. There just aren't. However, AI does hold promise for enhancing various aspects of healthcare, including what we do, including musculoskeletal care. But we need to recognize its limitation and help it, because that's one of the cool things. One of the cool things about chiropractic care is that we're already on the cutting edge. We're already looking for any possible way to help our patients more. And I think that we can do that if we can understand how AI has challenges, but how we can help it accurately diagnose those musculoskeletal conditions, how we can navigate these limitations, and we can leverage technology to augment rather than replace human expertise. So I do not believe that chiropractors will ever be replaced by AI. I do believe that we're going to have a pivotal role in shaping it, one, for our profession, but two, and possibly just as important, for the patient. Now, we just went through a bunch of stuff about AI. Let's talk about the EHR, because that's what's on the top of my mind, because now we have scheduling, we have our notes, and we have billing all running in our clinic, Premier Rehab. We've been doing notes for almost a year now, so we have some efficiencies built into that that have changed over the last couple weeks to months, but really not a whole lot. I do think that one of the biggest things now is the billing engine. Billing is something that it scares me, I'll tell you that. However, we now have integration into a clearinghouse. So literally, I have a note that is billed and sent out to the insurance company before that patient checks out. It's that fast. That's something that I think is going to be revolutionary to the way I practice. And then the cool part about that integration, is a full integration, is that remittance comes right back in to that patient invoice. And also the payment integration, we use NCMIC for that. Tremendous team over there helping us do what we do, and have built a system that requires no reconciliation. There's always that hint of, can I lower my percentage? Can I decrease costs here? Can I decrease costs there? One thing that we found is that as soon as we started separating out all the different programs we use at Premier Rehab, we found that the way we can do that is through staff, because now staff has to reconcile credit card charges every single night to make sure it matches the EHR. And that staff time and overhead is the biggest thing that's impacting my current practice. So it's something that I'm trying to solve both in my practice, but also with the new EHR. So I hope this was an informative podcast. I just hit the 40-minute mark as far as my time, which I was told by my marketing team, don't go over 40 minutes. So I have already broken that rule. However, if you've enjoyed this episode, share it with a friend. Please do that. This is something that I think that is going to be powerful for the profession to hear different points of view. And I think that if anything in here inspired you to take a deeper dive, look into the different programs that offer AI in chiropractic, whether it's a marketing program or whether it's an EHR. This podcast is all about pushing our profession forward, and it cannot happen, and it would have not happened without you guys, the guys and gals who email me with both good and bad criticism for both blogs or webinars or podcasts. I really do appreciate. And this is one of the ones that I wanted to do, not because people asked me to do it. It was actually because of the reason that most people said, hey, we don't want AI. And I think that in the absence of clear communication, people will always expect the worst. And this is one that by no means do I think is all sunshine and rainbows. However, the incorporation of AI into everything, it's already there. The question is, how are you going to utilize it? And I think this is one of the ways that we can utilize it as a profession to help propel the profession forward. Thanks for listening. Any questions, concerns, Brandon, BRANDON, @chiroup.com. Thanks for listening.